Good evening. You are watching Dr. KK's Med Talks non-stop show. Welcome to Med Talks Live, conversations that matter, an educational initiative supported by Eli Lilly. I, Dr. Rahul Bakshi, am your host for today's session. Obesity is a chronic and relapsing condition influenced by complex biological, psychological, behavioral, and environmental factors. While many individuals successfully lose weight initially, maintaining long-term weight reduction remains a significant challenge. Patients often internalize guilt and shame, which can negatively impact self-esteem, mental well-being, treatment adherence, and motivation to restart healthy behaviors. Therefore, addressing the emotional burden associated with relapse is essential in obesity care. This session aims to foster understanding, normalize setbacks, and encourage patients to adopt a compassionate, sustainable, and a science-based approach towards long-term weight management. Let's start the session. Here are today's key updates on obesity. Major So here are today's key updates on obesity. Major BMJ meta-analysis confirmed rapid weight regain after stopping obesity medications. The American Society for Metabolic and Bariatric Surgery recently issued a statement recognizing that weight regain after bariatric surgery is common and treatable. Several recent reviews highlighted that hormonal and metabolic adaptations after weight loss increase hunger and reduce energy expenditure, making relapse biologically common. A recent systematic review found that while medications help during treatment, long-term maintenance still depends heavily on sustainable lifestyle and behavioral changes after the therapy. And newer obesity medication discussions now focus on precision nutrition, microbiome-based personalization, and individualized obesity management to improve adherence and reduce recurrent weight gain. So now let's go to the topic of the day. Now I'll introduce our guest for today, Dr. Sambit Das. Dr. Sambit Das is a distinguished endocrinologist and a diabetologist based in Bhubaneswar, Odisha, with over 13 years of extensive clinical, academic, and research experience in managing diabetes, obesity, metabolic disorders, and endocrine conditions. He currently serves as the professor and head of Department of Endocrinology at KIMS Medical College and Super Specialty Hospital, widely respected for his patient-centric approach and expertise in obesity and metabolic health. Dr. Das has been actively involved in advancing awareness and education around lifestyle diseases. His practical insights and empathetic communication make him a trusted voice among patients and healthcare professionals alike. So now we'll move on to the discussion. Welcome, Dr. Das.
Thank you, Dr. Rahul, for those kind words. Very good evening, one and all.
Sorry, I'm not able to hear Dr. Das.
Okay, just hold on. Am I audible?
Yes, sir, you are audible.
Yeah.
Okay, sir is audible, but I am not.
Sir, can you hear me?
I can hear you, but I can't hear Dr. Das. Anything I can...
No, sir, because as you can hear me, there shouldn't be any problem.
Okay, fine, I'll try and continue. Okay, so I will start with the first question. Dr. Das, is weight regain common after weight loss?
Thank you, Dr. Rahul, for those kind words and a very good evening, one and all. And at the outset, I must thank IJCP and the MedTalks for this opportunity. So, Dr. Rahul, you have actually highlighted a very important topic, that is weight regain common after weight loss? And the simple answer is unfortunately yes. Weight regain is very common and happens to many people after initial weight loss. So you'll just lose weight and then try to gain weight. So that's the usual tick shepherd curve for the ominous tick shepherd curve for obesity and the weight loss. Obesity is a chronic condition, and maintaining weight loss often requires long-term support, lifestyle adjustment, and sometimes medical treatment. And many times, once the person loses weight to some extent, with lifestyle, with diet, with exercise, with medication, or with bariatric surgery, there might be some weight regain. And it has been thought that probably if you are losing by any method with weight loss, maybe after 2 years, if you are leaving that procedure, or you are leaving that measures, then probably you will gain around 50% of the weight lost within the next 2 years, and maybe 80% within the next 5 years. So weight regain is very common in the journey of weight loss.
That's great, Dr. Das. So why does the body try to regain weight biologically?
Yeah, that's also a very important concept, and here many of our audiences are there who might be living with obesity, and that's the thing which I wanted to highlight, is that the body is a biological phenomenon. Never think that it is basically you eat more and do exercise less and finally you gain weight. It's not like that. There are so many biological things that plays into role, and the appetite depends on many factors, and similarly the weight loss also depends on many factors. So once after weight loss, or some of the weight you have lost, the body tries to regain that. It comes to that set point where it has left you. So there are many hormones which increases the hunger, so that hunger hormones rises up once you lose weight. Then there are many satiety hormones. Those are released either from the gut, for example, the GLP, GIP, or the cholecystokinin. There are some hormones from the adipose tissue like leptin, and there are some hormones in the brain. So they all lead to satiety. But once you lose weight, those satiety hormones are also reduced, and the hunger hormones like ghrelin increases. The fullness signal may reduce, so you may not feel full when you are eating less, so you may require more food for that fullness. And metabolism also slows down, so once you lose weight, your metabolism also goes down, so the body tries to conserve energy. So all these factors finally lead to gaining the same weight which you have lost in due course of time. So that's the biological phenomenon of weight regain.
Yes. So, Dr. Das, when many of our patients try to lose weight, say with diet and exercise, or say with one of the newer GLP-1, GIPRA based therapies, many of them would probably regain some weight as well. So, is this weight regain or relapse a sign of failure or part of the journey?
Yeah, that's also very important, because remember that weight loss is a journey. It's not a point where you have reached and then you tell, I have lost my weight and I have reached my target. It's never like that. It's a journey, and it's a relapse and recurrence. So that's why we call obesity is a chronic relapsing complex disease, and the relapse is not a personal failure. So many times, when our patients living with obesity, with lifestyle measures or medication or with surgery, they lose weight and then they try to regain weight because of the biological phenomenon which I have explained. They think that this is their personal failure, and that actually demotivates them, that stigmatizes them. So relapse is not a personal failure. So that's the first point which I wanted to highlight. It is common part of the obesity management journey, similar to fluctuation in any chronic disease. For example, now WHO has recognized and many associations have recognized that obesity is a chronic disease. Like in any chronic disease, say for example, someone is suffering from diabetes, someone is suffering from hypertension, someone is suffering from MSLD or any other chronic disease. So what happens is that in diabetes also you have fluctuation in the blood glucose. So you need to meet your doctor every 3 months. You control the blood glucose and so on and so forth. Similar is the obesity. So weight fluctuation is a part and parcel of obesity journey, and the fluctuations are similar to that of the any chronic diseases. So what matters most is recognizing it early and restarting the support without any stigma. So we must restart that support system. We must take the patient's confidence. We must discuss with him that this is part and parcel of your journey, and we have to bear with that, and we will do appropriate intervention to reach to the target. So that's how our approach to a person living with obesity should be.
Right, Dr. Das. And how can patients overcome guilt after regaining weight?
Yeah, so this is a very complex thing, because once people living with obesity they regain some weight, they actually feel guilt. They Many of our patients, so they think that this is their personal failure. They have eaten more. Nowadays is the mango season. Nowadays some festivals are going on, so they themselves will tell, sir, I have taken more mangoes, I have taken more sweets, for that reason probably I have gained weight. But that is part of the fact. Actually, this is not the whole fact, and that guilt actually further leads to more vicious cycle, and the person enters into a vicious cycle, and that ultimately harms the patient, and that probably prevents the person from achieving the target. So patients should remember that weight regain is influenced by biology. I have discussed about the satiety hormones, the appetite hormones, the ghrelin hormones. Then stress comes into place. So stress is also a very important part of regaining weight. The environmental itself is a major role. The family support. The sleep is also very important. If someone is in stressful condition, the sleep goes down, and that again helps in regaining the weight. The emotional situations, the medication. Sometimes the person not only lives with obesity, he or she might be living with diabetes, and we have given some drugs that can increase weight, for example insulin, sulfonylurea, or pioglitazone. So that factor also needs to be taken care of, and also the lifestyle factor. So it is not just the willpower. So we need to be compassionate. We should reconnect with the patient, and we should be focusing on the progress rather than perfection. So that is the simple motto for obesity management. We should be believing in the process rather than target oriented, or it is not a perfectionist approach. We should holistically approach the patient.
Yes. So interestingly, Dr. Das, you mentioned about stress. So a lot of patients will ask, does stress contribute to relapse? You did mention yes. Can you elaborate a bit on that as well?
Yeah, absolutely. So stress is an important factor, and that is one of the important etiology of obesity, and that is one of the most important etiology of regaining weight, what you have lost. So stress can increase the emotional eating pattern. So many times you might have seen that people who suffer from anxiety, depression, they actually tend to eat more at the wrong time. There is a concept of chrononutrition. They start eating more at the night time, midnight snacking, frequent snacking. So that all increases, the craving increases. Stress also reduces the sleep pattern, so the sleep also gets derailed. And finally the motivation decreases. So once you are stressful for some other thing. You may not sufficiently give time to your own body, and you may not exercise more, or you lack the motivation. So stress actually does all these harms to the person. Beside that, we also know that stress actually increases or deranges some of the hormones, and most important is cortisol, maybe epinephrine, norepinephrine. So the cortisol level goes high with the stress, and once the cortisol level goes high, it actually increases more of adipogenesis. There will be more of abdominal fat. There would be poor fat distribution and fat storage system. So all this can lead to more of relapse in the obesity.
Okay. And how should families support someone experiencing weight regain?
I think family is a very very important component in the weight management schedule. So, so in my clinical practice, and also it is the recommendation what we also do for that, the family should be taken into account, because otherwise you just cannot target the person with obesity. There you have to target the entire family. The person who is cooking in the family, the amount of physical activity the family does, the sleep pattern of the family, the screen time of the family. So everything comes into the family as a whole, as a total. So family should avoid criticism. So many times there will be members in the family who will be telling, you are not exercising, you are a couch potato, you are just sleeping and watching TV and mobile. So that's how we are gaining weight. But the biology I have discussed, it is actually biology rather than only the patient's neglect towards his health. So family should avoid criticism, teasing, or constant monitoring of food habits. So if someone in your family is trying to lose weight and you constantly monitor their food habit, what they're eating, what they're not, then they get frustrated, they get irritated actually. So those holistic approach has to be taken care of. Instead, they should provide an encouraging environment, participate in healthy routines. So if someone is trying to lose weight, he's doing exercise, think of the whole family. Maybe the wife is also working with him, the child is also working with him. So the whole family is actually in a good lifestyle, and that changes the person's behavior or perception towards his lifestyle. And family should create a supportive environment for the person who is trying to lose weight, rather than giving a blame game, or rather than stigmatizing the patient.
Okay. Dr. Das, when you see a patient who is on his weight loss journey, is there any way that we can recognize early signs of relapse?
Yeah, that's important, because we need to find out at what time the relapse is happening so that we can take corrective measures at the earliest. So there are some subtle signs you will find. So suppose someone is losing weight, and then he or she has lost a follow up with the doctors, maybe a nutritionist. They have not contacted the doctor or the nutritionist at the proper time. They have not checked their weight. They've not they failed their clinic visits. Slowly the portion size is increasing. Suppose the person was taking a small katori of any food material, the portion is increasing. He or she is taking a larger plate. He or she has started taking more of sweets and all. Frequent snacking and emotional eating. Physical activity has come down. Sleep has become irregular. So all these are early signs where you can actually find out that relapse is probably happening. And at that time, one has to be very careful as healthcare providers, as endocrinologists, diabetologists, or obesity physicians. We must target at that time, and the earlier we target, we can actually intervene at that time, rather than leaving the person for a longer period of time. Then he or she may have regained around 50-60% of the weight. At that time, it would be still difficult to come back to the original weight. So
So,
early
if
recognition helps
yeah,
prevent major regain.
yes, doctor. So, if patients regain weight, should treatment strategies change after weight regain?
Yeah, sometimes yes, because if someone is regaining weight, then we have to find out what is the cause behind that. The reason behind the regain should be definitely reassessed. Patients may need adjustment in the nutrition plans, adjustment in the physical activity. Behavioral therapy needs to be further further robust for the patient. Sleep management has to be proper. Medication, if you are giving, whether you are giving some medication that can increase weight, that you have to bear in mind as healthcare professional. And if someone is losing weight, but suddenly he or she has started gaining more weight, then we have to evaluate hormonally also. Sometimes some hormonal tests we have to do, psychological evaluation we have to do. So the treatment strategy definitely changes, because we need to find out what is the cause behind that weight regain, and the exact cause needs to be addressed. So that's how we go during the relapse.
Right. You mentioned about hormones. So, my next question is regarding the same. Can hormonal adaptations make weight maintenance difficult?
Absolutely, yes. Because I have discussed some of the hormones actually, those who are satiety hormones, those who are orexogenic hormones or anorexogenic hormones. So we call them orexogenic when the appetite increases with their stimulus. For example, the ghrelin released from the stomach. Then there are hormones that actually reduces the appetite. For example, the GLP, GIP, the peptide YY from the intestine, or the leptin from the adipose tissue, or from the pancreas, you will have insulin and all. So those are actually reduces the appetite. So these are the hormones that play a long role, and the hormonal changes after weight loss can increase the hunger and reduce the satiety, reduce the energy expenditure. Hormones such as leptin, ghrelin, insulin, cortisol, what I have told, and GLP-1 may influence the appetite and metabolism as a whole. So, making long-term maintenance of biologically reduced weight is sometimes difficult. So, that where the intervention is actually needed from healthcare professionals like us.
Okay. So, Dr. Sambit, how important is long-term follow-up in obesity care?
Yeah, I think that's important because at this program, I just wanted to highlight that all the audiences who are listening to me must recognize obesity as a chronic disease. It's not a lifestyle disease. You just cannot tell it. It's because of you are eating more, you are exercising less. That's why you are obese. It is in fact a chronic and complex and relapsing disease. So that's what I wanted to highlight in this program. And like any chronic disease, so many of your family members might be suffering from hypertension, diabetes, or any COPD or any chronic disease. Like, you follow the person, you follow him or her every 3 months. You do the tests, like for diabetes you do HbA1c, lipid profile, creatinine, and all those things. The exact thing holds good for obesity also. Obesity is a chronic disease, and we must understand that, and we have to follow it for a long term. Long term follow up is extremely important, and regular follow up helps identify the relapse early. So, not only we have to follow them up, we have to find out at what point they are developing complication, at what point relapse is happening, at what point the weight has been static, and for what reason. So, all these things has to be monitored. The patient needs a long-term follow-up in the obesity care. So obesity care is a long-term journey. It cannot be told that you have achieved the weight and that's done.
Yeah. Dr. Samit, earlier you also mentioned about emotional eating. So we want to know, what role does emotional eating play in relapse?
Yeah, emotional eating is in fact a very recognized terminology now, and emotional eating is a major contributor to relapse. So, people may eat in response to stress. If they're lonely, they will eat more. Anxiety, they will eat more. If they're frustrated, if there is boredom, there is sadness, they eat more. And this is not something rocket science I'm telling. This has been recognized for a long period of time. So there is a condition known as emotional eating, and anxiety, depression, sadness actually increases the emotional eating. And when someone is losing weight and this psychological thing comes up, then probably you will eat more and the hunger increases, and then you land up in weight regain. So it's one of the most important cause for relapse in obesity care.
Dr. Sambit, we all understand the importance of diet in journey for weight loss. So should patients restart the same diet plan after regain, or would you want to make some changes?
Not exactly. So, if someone has failed on a given diet and he or she has started regaining the weight in the same diet, then we have to think twice why that diet is not working. If many times what happens is that we offer the person a very restrictive coercive diet, and initially they may obey for 15 days, 1 month. They may lose weight also with that, but gradually they completely discard that diet, and that happens with many fad diets. For example, the keto diet, the paleo diet. So patient may like it for 15 days or 1 month, they lose weight, but then they completely leave that, and that produces more weight regain. So treatment should focus on a realistic pattern. It should be a smart pattern that is specific, measurable, and target oriented, and it should be flexible also. So you cannot tell a person living with obesity, living in Bhubaneswar, to practice a complete Mediterranean diet and take only turkey or chicken and don't take any rice and all. So we have to be culturally adaptable also, and it should fit into the sustainable habit. So the person should able to maintain that diet for a long period of time. So that's the crux of a good diet, and individualized lifestyle modification and the healthy diet is part and parcel of the therapy.
Okay. How can mindset coaching help during relapse?
uh, it's very important, in fact. So the behavioral therapy is a very important component of management of obesity. So if you take up any guidelines, any good tertiary setup for obesity, so there are endocrinologists, there are obesity physician, there are nutritionists, there are physiotherapists, there are bariatric surgeon. But at the same time, we should have someone from psychiatry, from a psychological counselor also. So he or she has to do a mindset coaching, otherwise the entire therapy will is going to fail in due course of time. So mindset coaching can help patients develop resilience, self awareness. That means at any time they're diverting from that, so they should be aware of themselves. Stress management, it helps a lot. Healthier thinking patterns, it will help. And overall, it will give you a positive mindset. It shifts the focus from guilt and punishment to a more positive attitude, so that the patient maintains a sustainable lifestyle.
Great. Uh, you have partly answered this next question, but I'll still go ahead. So, when should medical reevaluation be considered in such patients?
Yeah, I have discussed that also, but again, it's important. So I have to discuss it again. So remember that medical reevaluation is important when there is a relapse. So when the and not every time we have to evaluate it properly, but the red flag signs are when the regain is very rapid. So when someone is actually losing weight, but suddenly there is a weight regain. So what is the cause for that? We have to find out. Hungers become excessive, so sleep problems worsens. Medications may be contributing. So someone has started new medication and the person is regaining weight. Emotional health declines, so someone has gone into acute stressful events, so that's also a red flag sign. Existing medical conditions becomes uncontrolled. So these are the time when a proper medical evaluation by a physician has to be done. And doctors may reassess the three important M's. I call it, I remember that with a mnemonic: three M's: medical, mechanical, and the metabolic. So medical, mechanical is you have after the sleep apnea, you have osteoarthritis. The metabolic is diabetes, hypertension, dyslipidemia, MSLD. Mental is when there is anxiety, depression, psychosis, and all. So these three things have to be properly reassessed again during the reevaluation of when someone is rapidly regaining weight.
Okay. What message should doctors give to patients to reduce shame and stigma?
Okay, so that's important because doctors should emphasize that obesity is a chronic condition. And during my discussion with you, I think at each point I'm telling obesity is a chronic disease, and the doctors should recognize that it's not only a chronic disease, it's a complex and relapsing disease. And the physicians, the patients must understand that it is not a character flaw. So we should actually refrain from healthcare perspective to tell that it is your fault. You are eating more, you are going out more, you are eating more, you are doing less exercise. That should not be the core issue. We should discuss with the patient what are the things that is creating obesity, or which is increasing their obesity, and why they are not losing weight. Patient deserve evidence based care, and we should tell them the evidences which are coming up, what are the drugs coming up. We should be empathetic. So empathy is very important. Motivational interviewing we should do We should ask open-ended question. We should be using good language to the patient. There should not be We should not be telling you are obese, you are fat, or something like that. So we can just tell that we are going for your weight management. Your weight is a issue, and we are going to address that. We should address the patient with dignity, and we should give them the long term support. So remember, it's a teamwork. So for any obesity clinic, you have the nutritionist, you have the endocrinologist, you have the bariatric surgeon, you have the psychiatrist, or you have the physiotherapist. But uh, only those, they do not form the clinic. The supporting staff, the receptionist, the person who weighs the person, weighs the person living with obesity, all those things, all those people should be empathetic to the person. They should not be laughing, they should not be passing loose comments. So those are very important. And the third and most important thing is that it is a continuous phenomenon, obesity management, and it is a journey. Relapse is common, and we need to address that. A setback doesn't erase the progress. Relapse is not the end of the journey, it's an opportunity to restart again. So that's how we should tell our doctors to adapt in a clinical practice.
Okay. So now that was the last question from my side, and now we'll move on to some questions from our audience. So I'm just going through some of the questions which I mentioned, which I'll present to Dr. Das. Dr. Das, there's a question from Ada Afshin. How can patients stay motivated when weighing scale starts increasing again?
So, in fact, I have already told that weight loss is a journey, and in a journey, you will have bumps and humps. So, sometimes you have small accidents also, but you should not be demotivated at that time. So, weight regain is not your fault. It is a biology. It is the genetic. It's the environment. It's the biology. It is the hormonal component which is also playing a role. So, at that point, probably you should be more aware. You should adhere more to your lifestyle and diet, and come back to your doctor or endocrinologist or bariatric physician, and they will guide you definitely.
Yeah. There's another question. I'll read out the question, but you already mentioned it in detail in the talk. So I'll request Nabi, Nabanita Ghosh to go back and see the recording. But I'll read the question. Why do many people regain weight even after sincere efforts to lose it? This has been very well answered. So
Yeah.
now, Dr. Das, I would like to ask you, there are no more questions in the chat. I would like to know your opinion on a couple of things. One is like when we see a patient, who comes to us with hope of losing weight. They talk about various options. They talk about the newer GLP, GLP-1, GIP, RA therapies. And many times they would ask you, doctor, how much weight will I lose with this? They'll have a common question because there's so much excitement around these drugs. How do you handle this question particularly?
So yeah, so that's a very tricky question, and I think we all must feel fortunate that we have some good molecules which are currently in our market. Like we have the GLP and GIP combined analogs like tirzepatide, or GLP-1 analogs like injectable semaglutide. They are really good drugs, and they've been tried globally also, and if you say tirzepatide, then the weight loss with the highest maximal dose may be around 20-25%. Also similar with the injectable semaglutide, there is a 18 to 20% weight loss. So they are at par with the bariatric surgery also. So they are good drugs, but at the same time, remember that there are people who may not respond to the therapy also, and I always tell, whenever any of my engineer or software patient comes and they tell, doctor, how much I will lose at how much time. So I tell that it's your computer or your machine may follow a pattern, but human body doesn't follow a pattern. This is the engine created by God, and it doesn't follow a proper pattern. So you must recognize that we are giving the therapy with an intention for lose weight, and the evidence suggests that you will lose around 18 to 20% weight, or with the highest dose you can lose up to 25% or 26% of weight. But it is not for all. You may not lose weight. So, for example, in people with obesity living with diabetes, the weight loss may not be that sufficient. Suppose a person with obesity comes with endocrinopathy, something like hypothyroid, Cushing's, or anything, they may not lose weight. So we have to tell the patient, and we need to counsel the patient that it is a multifactorial disease. We have to control your diet, we must advise you exercise, lifestyle is the paramount. At the same time, we are giving drugs. Combinedly, it will definitely do good result, and the evidence is suggesting that probably it will work for you. So it is all an open-ended.
Great. Dr. Das, one more question. Where do you see with these wonderful option of drugs which we have today, injectable as well as oral, and some more in the pipeline, as you know, where do you see bariatric surgery today and after 5 years?
See, the bariatric surgeons should not feel bad because they are still, still a part of the obesity clinic, and at present also they are part of the obesity clinic. See, there are definite indications for bariatric surgery also. For example, the Western guidelines tell it is more than 40 or 35 with risk factor. The Indian guidelines tell if it is the BMI is more than 37.5 or more than 32.5 with other comorbidities. The target has also been lowered by the obesity society and the bariatric society to up to 30 with comorbidities if they have not responded to pharmacotherapy. So there is definitely a role of bariatric surgery, and bariatric surgery weight loss is still a little bit more compared to the tirzepatide or to the injectable semaglutide. But again, I think the craze of obesity surgery has definitely declined, because previously we have only one drug, that is Orlistat. We had only lifestyle modification with that, and the loss of weight was around 5 to 6%, and the bariatric surgery used to lose weight around 30% and plus. So there is a lot of gap in between, and physicians have got no choice but to ask the patient to go for bariatric surgery. But that gap now has been fulfilled with the introduction of tirzepatide or semaglutide. So there is a place for bariatric surgery, I'm not denying, but definitely the importance of GLP and GIP has gone up.
Great. Okay, I'll have one more question. So, how can patients manage cravings during periods of stress or emotional distress?
Yeah, so management of craving is difficult, and I just wanted to tell that actually our appetite depends on three factors. One is the homeostatic eating. So when you actually feel hunger, your body has got lesser food, and you want to take food, and there are many hunger signals and satiety signals to operate during that time. Then there is one hedonic eating, when you eat for pleasure. Suppose you are passing through a pastry shop, you have tasted that pastry beforehand, and it is very tasty, and you want to eat even if you do not have hunger. So that's known as the hedonic hunger. And finally, there is a frontal cortex control of your hunger. So the higher function will tell that you should not be eating at this time, or you should eat at this time. So these are the three different steps that our body has, and at each step it fails actually. So each step it may fail. So basically, when there is a homeostatic hunger, or there is a hedonic hunger, so mostly it is hormone related, and hormonal disbalance. Many times it is stress related. So we must address the person about those cravings, that probably it is related to your stress and your anxiety and depression component. So probably a psychologist help should be sought. And if there is, we also know the biology of craving. Some food material will increase the craving. For example, if you are taking more of carbohydrate, then probably your craving increases, and if you are taking more protein, then your craving comes down. So if you change the macronutrient composition of the diet, you increase the protein, you reduce the carbs, then probably your craving will also go down. So these are some of the things we can do. After that, if still the craving is there, then we have drugs. I've just mentioned, like GLP-1 or GLP-GIP agonist. So they are very good drugs for controlling the craving. So those things can be tried.
Great. Uh, After achieving their weight loss goals, should patients track their weight regularly?
Yeah, that's very very important. And see, the obesity is a journey. Like for any diabetic patient, if I ask all of you who are listening to me, what you do, I do monthly fasting pp, or every 7 days fasting pp, I do every 3 monthly hbnc. Similarly, for weight you need to monitor, so monitoring is very very important. So you have to check at least in a week or maybe in a 10 days in a single weighing scale what you possess by yourself, and you measure that, you can note down that, so that it helps in your it helps for your bariatric physician or a obesity physician or an endocrinologist to track your weight, so that the early sign of weight regain or static or the plateau of weight we can know, and we can intervene at that time.
Great. I think we've covered most of the questions. Some of them are just a repeat of what you've already discussed in detail in the session. So, if I'll just last time check again, and if there are no more, um, yeah, most of the questions you've covered. So, I would like to thank you, Dr. Sambit Das, for joining us today. And that will be all for today. Dr. KK's Med Talks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK's Med Talks. Namaskar.
Thank you. Namaste.